Alrighty, everyone, welcome back. Today we're going to be continuing our lecture on the lower extremity bones, starting off with the proximal part of the femur. So we just talked about the hip joint, or we talked about the coxal bone at the very least, but now we have the femur that is going to be the major thigh bone that is going to attach to the coxal bone. So to get started, let's bring up the PowerPoint and let's see what we have here. So we're going to be looking at specifically the hip joint, which is where the femur meets with the coxal bone, and all of its proximal bony landmarks and the ligaments that help to support it. So if you look closely, this is your coxal bone again. You can see that you have the ilium, the ischium, the pubis, and then a large hole called the obturator foramen. And then if you look closely, this right here, this very large bone with a round ball at the end of it, this is the femur. Now, this looks similar to another bone that we've looked at, the humerus, but notice there's a big difference here. There is a long neck for the femur. So the humerus did not have a long neck. It had an anatomical neck and then even a neck for the surgical neck, but this one has a pretty significant neck, which is going to be extending away from the shaft or the diaphysis of the bone. So let's go ahead and get started and look at one part of the coxal bone, which is actually a part that is a joint part between all three of the coxal bones. So as in it is partially made by the ilium, the ischium, as well as the pubis. And you can see that it forms this large kind of concave region that forms basically this big cup. This is called the acetabulum. And the acetabulum is where the femur is going to be able to connect. So this is going to be oriented laterally, as in this is going to be located on the outside of the hip so that the femur can sit right inside of it with its head. So if you look at the acetabulum, though, there are just a few different things that we can look for, starting off with this big thing in the middle. This depression is called the fossa of the acetabulum. So the fossa of the acetabulum is right here in the middle. And then looking along the edges, you can see that it forms this long crescent moon shape. And that's what it's named for, being the lunate surface of the acetabulum. And then at the bottom here, there's a small little opening that is called the acetabular notch. So the acetabulum, you can see, does have a few different regions, but overall, it makes this large cup shape on the lateral side of the coxal bone. Now, taking a look at the femur, you can see that there are quite a few little landmarks, even on the proximal side of the femur. So let's start off easy by taking a look at the head of the femur. So the head of the femur, as you probably have guessed, is this large rounded part. This is the part that connects to the acetabulum, but if you look closely, there's this small little depression right at the end of the head of the femur, basically. So this is going to extend medially into or towards the acetabulum, and we'll see that there's going to be a ligament attached there, but that little depression is called the fovea. So very similar to how you saw a fovea of the radius, like that small little cup at the top of the head, it's the same thing, but in this case, you can see that it's right at the end of the head of the femur. Now looking over here, you can see the neck of the femur. This is the part that extends outward medially from the shaft of the bone towards the coxal bone. That allows the head to extend or distend like a little bit away from it. But now we get into a few kind of more specific things. So to start off with, if you look closely, there are a few different bumps. So this is actually similar to what we saw on the humerus, but in this case, these bumps have a different name, which are called trochanters. So trochanters, these are going to be the bumps either on the lateral side, or in this case, the posterior side. So if you look over on the lateral side, this is the greater trochanter right over here, like opposite to the head. This is lateral, and then this right here would be the lesser trochanter. So greater and lesser trochanter, just like greater and lesser tubercle, these are indicating the size, but lateral is greater trochanter, posterior is going to be lesser trochanter. Now, relative to these trochanters, though, there will be a few or a couple different landmarks actually. So on the front of the femur, looking closely, here is your greater trochanter and then lesser trochanter. You can see a little bit of the lesser trochanter, even though this is the anterior side. But if you look closely, there is a faint line that is going to be right along the edge between those two, kind of like along the edge of the neck. That is going to be called the intertrochanteric line. So intertrochanteric, between the trochanters, this is a faint line on the front of the femur. So intertrochanteric line, but on the back of the femur, looking at the greater trochanter and lesser trochanter again, you can see that there is a large ridge here. Like this is actually a raised ridge between the two, which is going to be called the intertrochanteric crest. So intertrochanteric crest, that is going to be this region right here between greater and lesser trochanter. Now, one more thing relative to the trochanters is that kind of along the top of the greater trochanter, there is a depression there. That is going to be called the trochanteric fossa. So the trochanteric fossa, once again, fossa is like a depression. That is going to be the intertrochanteric fossa. Now, slightly differently named, but still somewhat kind of like in the same region, near the middle of the intertrochanteric crest. This is called the quadrate tubercle. So it's going to be like a small little bump on the front of that intertrochanteric, or sorry, in the back of that intertrochanteric crest. This is the quadrate tubercle. Now, looking down from the trochanters, you can see that, well, looking down from basically the proximal end of the femur, this whole part is the shaft of the femur. Now, if you look closely, though, do you see that there are major differences between the anterior and the posterior view? The anterior view is going to be kind of like what you'd expect for the shaft of the bone. It's a very smooth, kind of rounded surface. So very typical of what you'd expect for a bone to look like. But on the back of the femur, there's going to be a large ridge, and this is called the linea aspera. So the linea aspera is going to be this long ridge along the back of the femur. This is where a lot of different muscles are going to attach. But then there's also a couple of specific like lines that you'll look for as well, which include the pectineal line and the gluteal tuberosity. So it kind of extends away from the linea aspera, but over on the medial side, like near the lesser trochanter, this right here is called the pectineal line. So the pectineal line is going to be kind of like on the medial side of, or the pectineus muscle is going to be on the medial side of the femur, and this is where the pectineal line will be, where it's going to insert. And then gluteal tuberosity, gluteal tuberosity, I think we remember what the word gluteal means. Like this is where like gluteus muscles will be able to attach to as well. But this is going to be more lateral, kind of extending from linea aspera. And then medially, this is where you'll then get to pectineal line. So I know quite a few little things, but a lot of stuff does make sense to some extent, but it is important to also just differentiate. So especially when you look at the intertrochanteric crest versus line, looking at pectineal line versus gluteal tuberosity, like they're similar, but you definitely want to orient yourself correctly. So just to ask, do you think this is a left or a right femur? Like trying to consider which side is which. Anterior, posterior, medial, lateral. medial, lateral, and then proximal and distal. And with that in mind, it should be somewhat clear, but if this is the back, this would actually be the way it would be oriented in my body. And if this is medial and lateral, this would stick into the coxal bone, and this would be my right femur. So right femur on both sides. Now, looking at the joint formed by the coxal bone and the femur, you can see that you have that head of the femur fitting very snugly into the acetabulum of the coxal bone. And that's exactly what you want. Like, this is where you see bones fitting together, like ball going into socket. So given this, like, you have a very rounded surface, and this is going to allow for very, very like large range of motion. Like, this is going to be definitely multiplanar, very mobile. This is a diathroidal synovial joint, and triaxial means that it's not just like flexion and extension, it's not just abduction and adduction, but there's also internal rotation and external rotation as well. So this joint can basically do it all. Well, not all, but a lot of them. So just to like go over these real quick. Don't judge my background. I know what your places look like. I survived Zoom teaching. So let's just look at this real quick. Oh no. So flexion and extension is going to be going front and back. So front and back. When you decrease the angle of your hip joint, this is going to be flexion. You're decreasing this angle right here. And then extension is going to be the back going over back or posteriorly like that, which increases the angle of the hip joint. Abduction and adduction is very similar to what we like always talked about. So abduction is going away from the midline. Adduction is going towards the midline. And then internal and external rotation is just like every other rotation, but just keep in mind, like, you're rotating the femur. So you can rotate the leg as well, but when you rotate the femur, that is, oh, I'm not doing it. When you rotate the femur, that is going to be of the hip. So try to be careful of like when or where like the rotation is occurring, but you can see that there's a lot of different movements that can occur like along the hip joint. Now, in addition to the bones themselves, there's also a lot of supportive tissues as well. So first of all, this is a synovial joint. So as usual, there's a joint capsule, there's a synovial membrane, but there's also a lot of connective tissues, which we'll go over. So you can see a lot of them here. So the labrum probably sounds familiar because the scapula had a labrum as well, which is that border along the edge of the, in this case, acetabulum. And then zona orbicularis and retinicular fibers are part of the fibrous joint capsule, which are somewhat deep. And then you also have the synovial membrane, which is also somewhat deep. And then you have some extrinsic ones as well, which you can see kind of covering it here. So liofemoral ligament, that's this Y shape. Ischiofemoral, I don't think you can see that one that well, but we'll see that later. And then you have pubofemoral, which is down here. So pubo, do you remember what pubo or pubic is referring to? The pubic bone on the front, so right here. And then transverse acetabular ligament is actually like right near the bottom along the acetabular notch. And then ligamentum teres is a little bit of an interesting one because it's coming off of that fovea and then going into the acetabulum. So let's go over these really quickly, starting off with the labrum. So the labrum, just like what we saw on the coxal bone, for the scapula, is along the edge of the acetabulum in this case. And you can see that the labrum kind of extends outward a little bit, and it helps to just cup the head of the femur just a little bit more. So this is going to be fibrocartilage. It's going to form this like ring along the acetabulum, and it just helps to keep the femur in position and just hold it a little bit more strongly. So by extending out, it allows the hip joint to become a little bit deeper. So this helps to allow to sit in the coxal bone a little bit more snugly, but this is also going to just kind of hold everything together. It's going to help with holding the synovial fluid. It helps with making sure that it doesn't move out of place while it's in the or when it's in the coxal bone. So the labrum just is a largely important supportive structure, which keeps the head of the femur in place. Now, the joint capsule is generally on the outside of the inner portions of the joint, but you can see the joint capsule right over here, which is going to be covering basically the whole head of the femur, as well as extending out to the neck as well. So it starts out over here along the edge of the acetabulum, but then it goes all the way over to the intertrochanteric line and intertrochanteric crest. So going towards the intertrochanteric line and crest, like the fibrous joint capsule, is going to basically encapsulate the whole hip joint. But keep in mind, like inside of any given synovial joint, there is a joint capsule, but synovial membrane inside. So the synovial membrane, you'll be able to find inside of the hip joint, and this is going to be lining basically largely the whole thing, but there will also be some parts that also go kind of like deeper inside of the hip joint as well. But keep in mind, synovial membrane forms synovial fluid that's going to help with allowing to reduce the friction and the pressure within the joint. So instead of like having the bones or cartilage like going directly against each other, that synovial membrane and the synovial fluid that it generates is going to help with reducing that friction and pressure on the bones. All right, so that joint capsule is going to also be related to a few different ligaments as well. So if we look closely, there are a few different ligaments that we can see here that are going to be somewhat deep at the very least. So right over here, along the neck of the femur, you can see a little bit of this circular ligament or circular connective tissue, which is called the zona orbicularis. So we haven't talked about them yet, but orbicularis is a good indicator of a circular shape. So when we talk about like face muscles, you'll be able to see that once again, at least a couple times. And in this case, you can see it here as well. Zona orbicularis is going to be a circular part of the joint capsule that is going to be able to, well, kind of like encircle a little bit of the joint capsule and circle around the neck, basically. So it helps to reinforce and support the neck. Now, if you look here, kind of in the deep regions, so here's the synovial membrane, but like under the synovial membrane, this right here, this is called the retinacular fibers. So the retinacular fibers are going to be longitudinal, as in like not circular. They will be kind of straight from like head to neck. So this is where you'll have like blood vessels travel, but it's going to basically just travel along the neck of the femur. So pretty deep, retinacular fibers, and then zona orbicularis. Now looking at these two bones, like you can see that these landmarks fit together pretty like snugly. So there's also going to be like connective tissues that help with protecting them as well. So once again, you have the head of the femur, it fits inside of the acetabulum, but just to be clear, there are a couple of things that will be helping to protect them as well. So for many synovial joints, and in this case, there's going to be an articular cartilage. So the articular cartilage is going to be made up of hyaline cartilage. You'll see that it's going to be surrounding the head of the femur, but it's also going to be inside, surrounding the acetabulum as well, along the lunate surface. So the parts that are going to be in high contact, the head of the femur and the lunate surface of the acetabulum, that is going to have that articular hyaline cartilage. So this is going to be what helps to make sure that the bones do not directly grind against each other. Like the cartilage helps with, once again, protecting the bony tissue itself. So I know that bones are hard, but bones can also break if they are just to grind against each other. And if you're familiar with like what happens when bones grind against each other, it's with a singular word, it's pain. Like this is what it would happen like if you had arthritis and if the bones were to directly grind against each other, if the cartilage were to be diminished in some way, like yeah, it's not good. So along with synovial fluid and the articular hyaline cartilage, like these bones hopefully will be able to like be in like good contact, but also be able to protect themselves from each other. So hyaline cartilage covers the head, but with one exception, like it doesn't really go along the fovea of the femur. Now looking at some ligaments that'll be a little bit more external, like you can see that there are things that will basically cover everything that we've talked about. So notice you don't see the things that we've talked about, the orbicularis or the reticular fibers, but what you do see is, in this case, the iliofemoral ligament. So you can see it colored here in kind of like a pinkish color, a salmon color. There we go, salmon color. This is the iliofemoral ligament. Now, once again, just to remind yourself, where is the ilium in the coxal bone? So the ilium is going to be a little bit higher. It's going to be the large fan part. And if you look closely, there is this part on the back of the ilium, right over here. Or sorry, no, the front of the ilium in this case. The front of the ilium, because you can see the pubis. This is called the anterior inferior iliac spine. So anterior inferior iliac spine, this is where this ligament will connect to, but then it's going to branch out and bifurcate right here to go to the greater trochanter, and then also the intertrochanteric line along the anterior side of the femur. So this is where you'll see attachments from the anterior inferior iliac spine down to the front, and then a little bit of the bottom of the head of the proximal end of the femur. So when you do certain actions, this is going to provide like more reinforcement and more support. So thinking about this, what actions are going to cause this to become taut or stretched out? So you can see it in the slide, but imagine like if you were to pull your thigh posteriorly. So, all right, I'm gonna get up one more time. But when you pull your thigh posteriorly, like this, you're pulling on the front of the hip. So that is going to be hip extension, pulling on the iliofemoral ligament. And then also, when you do external rotation, you'll also pull on the ligament from the front. And then lastly, there's a little bit that's going to be, oh wait, no, that one's it. So hip extension and external rotation. So hip extension and external rotation, like those are the two that this is going to help with. Now looking at these pictures again, you can see the iliofemoral ligament. This is on the front, but on the back, Like if you look closely, this is greater and lesser trochanter with intertrochanteric crest. This is the posterior side of the femur. And attaching along the posterior side of the femur, you have the ischio femoral ligament. Now, really quick, consider, where do you find the ischium? It's in the back and bottom of the coxal bone. So on the back and bottom of the coxal bone, this is where you'll have the ischio-femoral ligament. So ischium is back here, femoral over here. So you can see it attached from ischium across the acetabulum over to, in this case, the neck of the femur. Now, in this case, like what actions are going to be causing this to become taut again? So this is a little bit odd, but even though it's on the back, it is going to also help with reinforcing the hip during hip extension. So it is kind of attached on the front side a little bit. So it does help with supporting external rotation, or sorry, hip extension. But on the other side, if you were to do internal rotation, that means that it's going to be being pulled forward. And being on the attaching side on the back, when you pull it forward, it once again becomes taut. But then one more, like when you adduct the thigh, when they become closer together, this will be taut as well. So being up here, like when you pull on the ischiofemoral ligament, or when you bring your thighs closer together, it is going to be taut during adduction as well. Now, at least for our big ligaments, you can see pubofemoral ligament, one more, which is going to the pubis in this case. So you had like iliofemoral, ischiofemoral, and now you have pubofemoral. So guess where this is going? It's going to the superior ramus of the pubis over here. So you can see that it's going from the femur along the acetabulum to the superior ramus of the femur. So, or sorry, superior ramus of the pubis. So this right here is the pubofemoral ligament, and this is going to help with, once again, being taut or supporting the hip extension. And then in this case, when you go outward, it's going to help with hip abduction. So when you bring your thighs outward, this bottom ligament is going to be taut. And then once again, similar to iliofemoral, it's taut during external rotation as well. Now the transverse acetabular ligament, like if you recall from the acetabulum, you have the acetabular notch. It's along that inferior aspect of the acetabulum. This right here is the transverse acetabular ligament. So this is near the bottom. It's kind of like the bridge along like the labrum where there's a gap. This is going to be the acetabular ligament near the bottom of the acetabulum. And we'll talk about these later, but there's going to be the obturator artery and vein that run beneath this ligament. And then ligamentum teres. If you remember like pronator teres or teres major, teres minor, like this is just like a short band. That's what teres means, like a band. And this band is directly connecting from like two things, one on one side or one on each side. And you can see that you have one end connecting over here to the fovea of the femur, and then you have the other end attaching to the acetabulum once again. So this is going to be a place where blood vessels can travel through. So this is important. So this is going to be taut during flexion and adduction, though, being that it's inside of the femur here, and when you move them in that way, it'll be taut. So talking about the hip joint, like there's a lot of stuff that's helping to support it. Like we have all of those ligaments, you have the thick fibrous joint capsule, you have the synovial membrane, but there's also a lot of stuff as well, like the labrum, just to remind you, that's supporting the head of the femur inside of the socket. And then I guess we might as well, like you have liofemoral, you have pubofemoral, you have ischiofemoral, you have the zona of orbicularis, as well as the reticular fibers. Like all of those things are helping to surround and support the hip joint. But then you also have a lot of muscles that we're going to see helping to support it as well. Like you do a lot with your hip, and there's a lot of stress on your hip, being that you're bearing basically your whole trunk of the body on this very angled joint, but you have a lot of ligaments that help to make sure that this is going to be well supported. Now, regarding blood supply, we will definitely talk about this more later, but just to bring up a few terms, well, first, medial femoral circumflex, lateral femoral circumflex. Like you have an artery and vein, which are going to be surrounding kind of like the neck and proximal end of the femur. So if you remember from the humerus, you had like anterior and posterior circumflex. It's a similar type of thing, but medial and lateral in this case. Now, obturator, I brought that up at least a few times, but obturator is referring to this hole right here called the obturator foramen. And going through there, there's going to be the obturator artery and vein, which are going to go to the medial side of the thigh. And then inferior gluteal artery and vein, this is going to be on the back side of the hip, so can't see that. And then a deep femoral artery and vein, like profunda femoral artery and vein. So that's another thing that we'll talk about as well. And then there's also like the cruciate anastomosis, which is going to help with the blood flow along the proximal femur. So that we can't really see it all, but it'll be there. Now, similarly, like we've talked about, like blood vessels, but nerves will be there too. And just thinking about names that we've used previously. So femoral nerve, like kind of like how you had brachial like stuff, femoral nerve in this case is for the thigh region. And then obturator, like obturator is not going away. You had that hole here. You had obturator artery and vein, but you have obturator nerve here going to the adductors. And then you have different branches of the femoral nerve, like going to the quadratus, oh, sorry, not. So you have different branches going to like the thigh region as well. One of the deep ones, quadratus femoris, is going to be a nerve going to that as well. And then once again in the back, superior gluteal nerve will be innervating this, but also gluteus medius and minimus too. Now, the femur, kind of like the humerus and the elbow, like it is not at a straight angle. There is an angle of inclination that's good to be kind of like aware of, which is that it's on average kind of around like a 125-degree angle. So 125-degree angle, like it's not 180, it's not like straight up and down. The neck isn't perpendicular to the hip bone. Like the neck is at a slight angle, which is 125 degrees. And if you look closely, like if you do, this is kind of like the normal stance, but if your if your femur were to be at a greater or lesser angle, it's going to cause your hip bones to be a little bit oddly oriented, either with your knees together or your knees apart. This would be coxa valga, where you increase the angle, or coxa vera, where you decrease the angle too much. And then in a similar way, you have a transverse plane angle as well, which is a little bit different, like for males and females, but for males, it's on average about 7 degrees. And then for females, it's on average like 12 degrees. And you can see like somewhat normal, 15 degrees here. But if you were to over-rotate or under-rotate, you would have antiversion. So Antiversion is when you increase the angle too much. And then retroversion is where you decrease the angle too much. So if you want to see that here as well, antiversion is where you have it like going too much forward. Retroversion is where you have it going too much towards the back. So with that said, that should be just about all that we have here for the hip joint or for the osteology of the hip joint. We'll be taking a look at the muscles like soon, just like last time, but let's go ahead and finish up for today. So good luck with your studying, and thank you for listening. I'll see you all next time.